Thanks everybody for joining us this morning for this presentation. Today I'm going to talk to you a little bit about the relationship between pain and social isolation and COVID. And I'm going to use social isolation and social rejection sort of interchangeably. I'm going to cover a little bit of the literature on the topic of social isolation and pain, or social rejection and pain. And we'll talk a little bit about what to do, but I think my goal here is really to raise awareness about the connection between pain and social isolation and get us all kind of thinking about this, about what to do, because as I search the literature, there is not really a good guideline. There are no guidelines out there about what to do. So this is from just random sampling of the internet of what you see out there that sort of relates to social isolation. We see these sort of snippets about people being stuck at home, can't connect, and their commute from home is their commute to work is from their living room. So we're all living through this. As we talk about this, I want to sort of give you a little bit of background on what pain is 2020. I'm going to run through this kind of quickly so we can get to that bottom one there on the slide: emotional pain, grief, rejection, social isolation. So there are four types of things that can, four events or four experiences that can start the pain circuits in the brain firing. So I'm defining pain as anything that gets the brain pain circuits firing. And there are two of them. I have a diagram of that in just a little bit. The first type of pain we're all familiar with. It's called nociception or nociceptive pain. That's a broken bone, a burn, a cut, that sort of thing. And what's going on there, the physiology of that is stimulation of specialized receptors in our tissues that are dedicated to warn us of impending tissue injury or actual tissue injury. So those are called nociceptors. That's why we call this nociceptive pain, or the process is nociception. We have specialized nerve endings that sense too much heat, too much cold, too much pressure, and inflammation, which is actually low pH. Once those are triggered, warning us of impending tissue damage, there's a signal that goes through the nervous system up to the spinal cord and up to the brain, and is perceived as our two brain pain circuits are activated. That's kind of hardwiring, I think, of a fire alarm. You know, the fire alarm going off when there's smoke or too much heat in the room. That's pretty simple to understand, and that's actually where I think most people sort of begin and end in their understanding of what pain is. The second type of pain is neuropathic pain from physical nerve damage or disease. So think of diabetic neuropathy. Think of people who have a sensation like they're walking on hot rocks when they're walking around on their carpet at home. Obviously, they're not walking on hot rocks, and there's no tissue damage. There's nothing wrong with the tissues per se. The pain is coming from within the nervous system. That's the key. Something is damaged in the nervous system. In an attempt to repair itself, the nervous system has changed the way it works. The pain-sensing nervous system will send pain signals to the brain when there's actually nothing going on in the tissues. This is really well studied. Probably the best example is phantom limb pain, I would think. So if you think about it, think about that first type of pain I described for you, nociceptive pain, and think about how that could explain phantom limb pain. It can't. How, if someone is missing their right leg and the brain pain circuits are firing and telling them that the right foot is hurting, but there's no right foot, there's no too much pain, too much pressure, too much heat, too much cold. That's not happening. It's actually kind of a lie that the nervous system is telling the brain as a consequence of nerve injury. So that's neuropathic pain from physical nerve damage. The next two are the harder ones to get our heads around, and I'm going to focus on the fourth. But the third is probably the elephant in the room when it comes to managing chronic pain and some of the wrong turns our healthcare system has taken in addressing the issue of chronic pain. 30 million Americans at least have a significant amount of chronic pain that interferes with their daily living, and this third and fourth, are pretty significant causes for pain in that group. So I'm talking about neuropathic pain. I'm calling it that, pain from in the nervous system, which is why I picked neuropathic pain, from a threat-adapted nervous system, meaning people have been traumatized. They've been exposed to threats they couldn't master at the time. That causes trauma. And their nervous system is reorganized, so if they ever meet that threat again, they're going to behave differently, or maybe to prevent them from ever meeting that threat again because they couldn't master it. So the process is similar to neuropathic pain from nerve injury, to what happens in phantom limb pain, but different. And it tends to engage the emotional pain circuits and other parts of the brain. That's got a fancy name. I just wanted to throw this out there. I apologize for geeking out on you folks a little bit, but I wanted to throw this out in case you ever run across this. The International Association for the Study of Pain, which comes up with the terminology for pain conditions, kind of like we have a headache society does that for headaches, calls that nociplastic pain. I hate the word, but I like the description. Pain that arises from altered nociception despite no clear evidence of actual or threatened tissue damage, causing activation of the nociceptors, and no evidence of disease of the nervous system. There's been no damage, physical damage to the nerves. So what they're saying here is it is not nociception, it's not neuropathic pain from physical nerve damage, it's something else. The problem with that definition is it doesn't say what it is. I think majority of the time that's trauma, the effect of trauma on the nervous system. So one more to go, and this is the subject of today's presentation, really, is emotional pain. Again, I'm picking that out of the air. We all know that depression can be painful in a way, but I'm talking about the brain pain circuits getting fired up. We could see it on a functional MRI from grief, rejection, or social or isolation. Those conditions are capable of firing up, lighting up the pain circuits, causing what we would call real pain because the pain circuits are firing, that at times can be indistinguishable from physical pain from the first time, from nociception. As a matter of fact, one of the things we do in our pain programs now is try to help people distinguish that first type nociception from the third and fourth type. Those are the four basic types of things that can get the pain circuits spinning. But of course, just to be complete, I'm going to tell you that once the pain circuits are firing, a person's culture, their beliefs, their values, their assumptions, that's going to be layered on top, and they're going to filter the pain experience through their beliefs, values, and assumptions. And the behavior that comes out could be very different given the same pain stimulus. So depends what's going on in someone's life. If we walk in an elevator and step on the toes of two people standing in an elevator, one got a raise, one got fired, we get a different result. Finally, anxiety and depression will make a difference, of course, on how we express and interpret pain. And the person's relationships with family, at work, and so on will, of course, have a lot to do with it. So occasionally we'll have somebody who their pain has become a way of interacting with the world. It's how they keep people distant or bring people close. And so the relational aspects of pain become very important. So that's what leads me to this, the pain cake. When a practitioner, behavioral health or medical, is seeing somebody who's talking about pain and trying to understand it, we cut into the pain cake and we try to look at what layers are important. These are all the possible layers once we open it. When a person, if anyone out there listening is experiencing chronic pain or has a family member or friend with chronic pain, if we want to understand, we got to cut in and look at what layers are really active. So we have the four types of things that can fire the pain circuits on the bottom here. One might be the active, two might be going together, all four. You can imagine that somebody who had developmental trauma, who got in a bad car accident, had traumatic surgeries, might have nociceptive pain from their back and from injuries, might have some nerve injury, have the second type of pain, has the pain of trauma, and also is grieving the loss of their job and their ability to interact with the world. So you can have all four. Cognitions and emotions layered on top, and then the relational consequences. So basic sort of understanding what pain is, let's talk about this a little bit. I promised the brain pain circuits, and here they are, just to be clear, because the next slides are going to, again, geek out a little bit on some of the functional MRI imaging, functional imaging of pain from social isolation and rejection. So we have two brain pain circuits. We have a circuit up here in blue called the sensory pain pathway. And what that does is register for us what's happening in what part of our body. So if I stub my big toe on my right foot, there's a part up here in this part of my brain, the parietal cortex up in here, that's going to register you have too much pressure in your right big toe, do something about that, move your right foot, not your left. There isn't necessarily any emotional content with that. Then there's this pain circuit, the emotional pain circuit. That is, you can see I've circled all the good parts of the brain that are involved in emotions, and in memory, and in controlling behavior. So that red circle is the part of the brain that registers the miserableness, the unpleasantness of pain, the affective component of pain. And we can see both in the upcoming slides, how both work together. So I want to convince everybody that social isolation and rejection are painful. And I want to show how much overlap there really is between our brain's response to being rejected or isolated and having pain from a burn or something like that. So let's jump into this one right here. This is a study that looked at people who had experienced social rejection. They had a breakup in particular. They looked for study subjects that had a breakup of a significant relationship recently. They scanned their brains, and they did it under two different circumstances. They did the functional MRI under circumstances where they said, gave them a picture of the person that had rejected them, said, think about them, think about the last time you talked to them, and then they did the functional MRI. The idea was to fire up the social rejection circuits, and they could see as the person was thinking about this person and the breakup and the rejection, certain parts of the brain light up, and that is in this dark red color here in all these different scans. They did something else at a separate time. They brought the study subjects back, and they put a heating pad on the thigh, and they heated it up until the study subject said, you know what, that really kind of hurts, and could you please stop? So getting close to a burn, but not quite. They scanned, they did the functional MRI, and that is the parts of the brain that were activated by the heat are represented in this orangey, yellowy color. The point of this slide is the overlap. You can see that in the emotional pain circuits, there's a tremendous amount of overlap between the two colors. The anterior cingulate up here and the insula here are lighting up, the thalamus and the insula are lighting up with both the pain stimulus, the orangey one, and the red one, both in thinking about the person that rejected them. So the author's conclusion is, it gives new meaning to the idea that social rejection hurts. That's a direct quote. Social rejection lights up the same parts of the brain as does physical pain, demonstrated here. There have been further, more high-tech studies of functional MRIs that are parsing out exactly which part of the brain is active that are modifying our understanding of this, but I thought this is kind of impressive just to see how the parts of the brain overlap. And in fact, even out here, this is the sensory experience of the brain in the parietal cortex. Even out here, there's almost complete overlap between the part of the brain that's activated by heat, pain, and the part of the brain that is activated by looking at the picture without any pain stimulus. So that's pretty impressive, I thought. Here's 3 more studies, which I put the references so you could look them up, that just show even further that social interactions mediate pain perception. So authors, without going into detail, have showed us in a number of human studies that socially isolated people have a lower pain threshold. Heat pain threshold, pressure pain threshold. It's been done a few different ways. They've also showed in people with rheumatoid arthritis that the degree of social support at the diagnosis, so this was smart, the investigators gave surveys and tested the amount of social support that a person had when they were diagnosed with rheumatoid arthritis. Came back 3 years later, they found out that the degree of social support at diagnosis strongly predicts how much rheumatoid arthritis pain they're going to have 3 years later. There's a strong correlation, positive correlation. And again, pain scores correlate positively with perceived social support in people with chronic musculoskeletal pain. I think they might have included mostly arthritis in that group. So if you just survey people and say, well, what's your perceived social support? The less the social support, the more likely they are to have high pain scores. So more of the same. Social isolation and rejection is painful. And one last one, which is really pretty good. These folks used a functional measure of pain, how much pain interferes with your life, a series of questions. Does it interfere with sleep? Does it interfere with mood, with activity, with doing your daily chores? And these folks followed a group over time, and they found evidence that the impact of pain is reduced over time in a group of people who feel a greater sense of inclusion, more social support. So again, if people feel better social support over time, pain doesn't bother them as much. So that's enough of that. I just thought this was kind of interesting. Tylenol, acetaminophen, reduces social pain. So here's an experiment, I just threw this in, a study where they looked at simply giving people Tylenol, acetaminophen, for people who had social rejection, and their pain scores decreased. So that's interesting because it says that something we think of as a pain reliever helps treat social pain, social isolation, the pain of that, and that sort of is further evidence of how much of the brain is really shared by social rejection, isolation, and how painful that is, and physical pain. We use the same circuits almost. Now, this is for you all to look at later. I'm not going to go through this in a lot of detail, but I just said that acetaminophen, Tylenol, can treat social pain. Well, the endogenous opioid system is involved in regulating social pain, the degree of social pain that people have from social isolation. And what they're telling us is that people who are more resilient tend to have more responsive opioid receptors in the correct part of their brain. And there's actually a gene, the gene for the opioid receptor, a specific allele of that gene, which will make people more sensitive to social rejection. If the endogenous opioid system is really important, you can kind of see how opioids would also treat the pain of social rejection and isolation. And that's kind of an uh-oh. That's something for us to think about as we go forward into the COVID crisis. And in fact, surveys of opioid prescribing have shown that people have increased, that healthcare providers have increased opioid prescribing during the COVID epidemic. And we've seen an increase in fentanyl overdoses. Are people treating the pain of social isolation with opioid? I would say probably. So here's kind of the overlap then. Social isolation increases pain. I've showed you some evidence for that. It also increases anxiety and depression, increases fatigue, and it aggravates some of the cognitive barriers to dealing with pain. Fear avoidance is the fear of movement. People are sort of stuck inside and they become more achy and they want to move less, and it becomes a spiral. The feelings of being misunderstood are aggravated by isolation. They worry about keeping up as they're being isolated, and somatization across the board increases. And of course, getting to help. I mean, how can you connect during COVID? And that's really, I'm going to wind this up in a moment. But the COVID-19 pandemic is interfering with transportation, with finances. Gyms and pools are closed. Alternative medicine providers are backing off or closing. Elective surgeries and procedures for pain have closed down. So it's really quite coming at people who have chronic pain from all angles. And there are certainly at-risk populations that have low social and financial resources, are IT challenged. A lot of our patients with chronic pain don't have a smartphone or a computer, or live geographically remote. So what do we do in the last few moments? Well, there have been a number of these webinars, these presentations that I think address this really well. They address self-care in particular, diet, exercise, sleep, meditation, and please, metering the news. I have to work on that myself. It's tempting just to turn on the TV when you get home and listen to what's going on, but boy, 5 days a week, that's rough. Connection to others and support groups are where I really want to focus on what we should be encouraging individuals to do. Treating anxiety and depression, and recognizing and treating trauma also would be very helpful. But how about connecting? I'm going to skip past that. And there are, at the end of this, there are a number of support groups that offer peer-to-peer interaction, and I've listed them here. So this would be for anybody who's looking to connect from their home, if you've got the electronics to do it. These 4 are pretty good. I put my chronic pain team here in purple in a different color because that is a for-profit organization. The others are nonprofit, but that's for profit, and they're going to be scraping up de-identified data on people for sale. That's the business model. Of course, NAMI has some great resources, but the American Chronic Pain Association, the National Fibromyalgia and Chronic Pain Association, and the Mighty, these websites offer people the opportunity to set up peer-to-peer and chat and blog groups and have them already going, which can be really, really helpful for folks. The last thing I'll say is when we're talking to people about this, I have a way of conceptualizing what's going on that has been helpful for me, and patients have given it positive feedback. When I explain to another person, and this could be a family member, a loved one, it could be if you're a healthcare provider, behavioral health provider to a patient, what's going on with the pain of social isolation on top of somebody who already has chronic pain. I simply explain that, we typically conceive of pain as coming from something wrong in your body, but that's not exactly true. That's where nociceptive pain lives. But the body communicates to the mind through the nervous system. And there's 2 types of pain that live in the nervous system. I've described them as neuropathic pain, from physical nerve injury and from experiential nerve injury, I call it here, from trauma. And then there's what I'm lumping together as emotional pain, grief, social rejection, isolation. Kind of artificially, because that's really the nervous system and the mind, but I put it over there to sort of help people understand, okay, if we're going to work on feeling more comfortable, we might have to hit all 3. Simply getting more medication and more procedures isn't necessarily going to do the job. How do we deal with the pain that comes from social isolation? The bottom line is reconnect. And I think that is a challenge for all of us. I'm hearing it from my colleagues during the COVID pandemic. How do we stay connected, especially if you're having to work from home? Keeping in mind that loss of connection can be painful, and being mindful that we could slide into taking more opioids or starting opioids as a response, which will modify the pain response from social isolation. but certainly has a cost and a risk. So we've got to find better ways. So with that, I'm going to stop and we'll see about questions here. And starting at the top. How do we help loved ones understand that pain is also emotional and can be treated with more than drugs? Well, hopefully I've just answered that one with sort of started with this framework. You can draw it out on a piece of paper, body, nervous system, mind, and talk about connection, exercise, diet, and sleep. That's how we get started. But the connection is going to be the really important one. And there's a question about the relationship between inflammation and pain. Well, inflammatory pain fits into that nociceptive pain category, that first one I talked about. That's simply specialized nerve endings that can respond to inflammation, because inflammation drops the pH of the tissues, and we really have pH sensors. That's what they are. But those that information has to be relayed through the nervous system to the mind. And if there's been nerve injury or trauma, and if there's isolation, that sort of gives the inflammatory pain a megaphone. It's going to amplify the amount of distress that someone is feeling from it. And someone said, a broken heart is painful. Absolutely. Definitely. Pain circuits fire. Just think of that functional MRI. That's why I showed them. Are doctors more cautious now in prescribing opioids? So I told you that surveys of primary care and pain clinics have shown that they're actually prescribing a bit more. And I'm afraid that that might be because people are home and hurting, because they're inactive, because the nociceptive pain is increased, but because of the isolation as well, and the difficulty in connecting. So recently we've seen an increase in prescribing of opioids, but the big trend in the last 5 years is a big decrease. I can tell you the data from the CDC shows that primary care and pain clinics have backed off, sort of a pendulum swinging back the other way, almost to a fault in prescribing opioids. So the national trend last 5 to 10 years has been a big, big decrease in how much opioids has been prescribed. I think about 25% or 30%. And the next one is, isn't there any evidence between opioids being more effective for emotional pain than non-opioids? No, not that I know of anyway. There are opioid receptors really densely throughout the circuits in the brain that respond to social isolation, which are overlapping with the circuits in the brain that respond to physical pain, to nociceptive pain. And the endogenous opioid system is a very potent and important regulator of the pain from social isolation or the pain from a broken heart. And that tells you that if you take an exogenous opioid, you're going to regulate those social isolation pain circuits. So opioid is effective. How effective? I don't know that anyone is going to design a trial to try morphine for social isolation. We have to get at that through a side door. So the literature on that is kind of thin. And certainly comparing to other methods of controlling pain, whether it's acupuncture, massage, meditation, I'm not aware of anything. Long answer to a short question. Let's see. About the connection with opioid receptors, tendency to feel social rejection, explain a bit more. Well, we've got about a minute left, and I want to respect everybody's time. And I would just say that the person asking that question, I've included some of the references there. Some of those studies are pretty interesting to read, and I might take a moment to go in and look those up and read them. I might answer that question. When something happens emotionally, affects someone, they say their heart hurts, that's a real physical feeling. Yes, it is. Pain is when the pain circuits are firing, period, end of story, no matter what got them firing. So we've got more questions. Last one, I'll sneak it in. Do you think that the serious mental illness community should be included in the at-risk population? Of course, because they tend to have lower social resources, financial resources, and a number of other factors that put them in harm's way. thanks for reminding me. And with that, I'll stop. And thanks everybody for taking a half hour to sit and geek out a little bit on the neuroscience of social isolation and pain.